I was asked to speak to you about data about quality of life from some big surveys that were done in North America and some parts of the rest of the world. Some ways about managing MPN, so I brought in some information from our service and some new treatments.
Okay. Det hun kommer til å legge hovedfokus på livskvalitetsstudier som hun har samlet inn fra en multi-internasjonal studie, og videre I forhold til nye behandlingsmuligheter og fremtidig forskning.
Okay. I usually make that we have some funding from our center and also in our patient group actually from some pharmaceutical companies. So this is the structure of what we will be talking about first.
Ja, det her på en måte da disposisjonen til hva hun kommer til å prate om.
So what is quality of life? When we think about quality of life, what does it actually mean? It's important to remember that it is not just about the symptoms that you have from your disease. It's also about many things that are listed on the slide. Maybe other conditions, your family, how much sleep you have, how much you enjoy your work. So it's the big picture for patients.
Ja, altså hun snakker om at livskvalitet handler om mer enn bare symptomer. Det på en måte hvordan man har det I hverdagen og livet I forhold til både økonomi, jobb og så videre. Da. Så det et stort bilde.
And on this slide, which came from my great friend Ruben Mesa, who probably many of you have heard or seen on the internet, he summarizes some of the things that he feels are important for MPN patients in the same way. So it's not just about the diagnosis. There are many impacts for patients and their families.
Ja, det her bildet har hun lånt av sin gode venn Ruben Mesa, som illustrerer litt på en måte alt rundt denne sykdommen da, I forhold til at det veldig sammensatt.
On this slide, we look at how is myelofibrosis, which is, this is not. No, not working. Well, maybe we can use this. This is myelofibrosis patients using a cancer quality of life score. And then these are the scores for patients, for example, with widespread cancer. And some of the scores for patients with myelofibrosis are at least as bad as patients with widespread cancer. So this is what makes us focus very much on quality of life for patients.
Ja, det hun viser på denne figuren her på en måte å sammenligne en sånn spesielt livskvalitetsskåringssystem på diagnosen myelofibrose og sammenlignet da skåren også for andre krefttyper da, og ser at de kommer ganske likt ut.
So for MPN and in the clinical trials, we've used a number of different scores that are now validated for use for MPN patients.
Det slik at I den livskvalitetsstudien hun har gjort, så har hun brukt flere forskjellige skåringssystemer, og de skåringssystemene på en måte godt validert, da, utprøvd I den populasjonen.
Yes. These also grew from a small seed, and the work of Professor Mesa, including fatigue, symptoms like sweating and losing weight, spleen symptoms, and then other things were added. So when the tools that we now use incorporate many different pieces of the disease.
De livskvalitetsstudiene som hun har fokus på, som bruker, det innebærer at dette har utgangspunkt I veldig mange flere symptomer enn det man har gjort tidligere.
And this has been translated into many languages, and I'm sure you probably use this also in Norway, don't you? So the story about MPNs affecting quality of life really started with the work of Ruben Messer and the work that he did with patients in America and then has spread across the world. And this has helped us to build a picture and build a story that actually patients with MPN have a significant burden from their disease. Not every patient all the time, but many patients have a significant burden, as you can see on the slide.
Ja, som denne sliden viser, som på en måte noe av det første som er gjort, viser at for en del av pasientene, men slett ikke alle, men for en del av pasientene så det betydelig reduksjon i livskvalitet og mange plagsomme symptomer.
Some people don't believe that.
Noen tror ikke på det.
So I will show you in the later slides some data to show that actually patients have more symptoms than people without MPN. Here is some more work which is important when I come to show you the landmark study. This is symptom burden broken down into quarters of severity. And actually, it doesn't really matter, for example, what disease you have. There are patients with a disease that we think medically is a less severe disease, like ET. Patients with ET can have a severe symptom burden as patients with what doctors think is a more severe disease, like myelofibrosis.
Den figuren her viser på en måte denne livskvalitetsscoren over kvartiler av symptombyrde. Da. Det en sånn statistisk måte å fremstille ting på. Og det hun understreker at symptomene kan være like ille selv om du har for eksempel essensiell trombocytose versus myelofibrose. Da.
So just for an example, because a complicated slide, here you see that 20% of the ET patients have the higher quartile of symptoms and around a third of the patients with myelofibrosis, just showing the equivalence.
Og som den figuren her viser, altså høyeste kvartil 4 betyr høyest symptombyrde, og da ser vi I forhold til disse dataene, så det 20% av pasientene med essensiell trombocytose som ligger I den kvartilen med høyest symptombyrde, og av myelofibrose-pasientene så det 36%.
There are some other things that severity of symptoms correlates with, as shown on this slide. Unfortunately, women seem to have a higher symptom burden than men. The type of diagnosis, but also there is some correlation in myelofibrosis patients with the severity of disease using a medical score.
Det også andre ting som korrelerer med økt symptombyrde, blant annet kvinnelig kjønn, MPN-diagnosen og forskjellige risikoscore.
So this is a picture to show you some work that was done supported by MPN Voice in Ireland and the south of England. And here they had NPN patients scoring their symptoms. That is this dark line here. And then they brought with them somebody about the same age who didn't have an MPN, and their symptoms they scored here in the pale line. And this is the first time in the simple study, supported by a patient group, that we showed that MPN patients have a more significant symptom burden than the general population.
Dette da en studie fra England som man da har målt denne symptombyrden hos MPN-pasienter og sammenlignet med en kontrollgruppe som ikke har sykdommen for å vise at det større grad av symptomer I denne gruppen altså.
Not very easy to measure symptoms in a medical clinic. And you'll see some of the data for how did the patients feel their doctors measured the symptoms. In my clinic in London, we tend to use a paper scoring system, the MPN 10. Maybe we also have it in a booklet. I know that your association produces a symptom diary. And we find this easy to use, but many patients have to make what their individual symptom is as a separate note. And I think there's also space to do that in the symptom diary.
Det utfordrende og vanskelig for doktorer å få en ordentlig oversikt og et godt mål på symptombyrden. Derfor så det på en måte da det å finne gode måter å få tilbakemelding blant annet på disse skåringsskjemaene og symptomdagbok som viktig I forhold til dette målet.
In the UK there's also an app that patients can use on their phone, which is sometimes quite helpful. So now I want to talk to you about the landmark studies about assessing quality of life. The first one I'm going to speak about is the one that was done in America.
Ja, når vi kommer nærmere inn på denne landmark-studien, og skal først gå litt gjennom hva man har funnet I USA.
So this is the title of the publication that came from this survey. Myeloproliferative neoplasms have a significant impact on overall patients' overall health and productivity.
Ja, dette da titlen på studien, altså starten på det hele.
So what this study did was they sent questions to patients through the internet, and also doctors answered questions. But the two weren't always matched up. So the patient wasn't always matched with their doctor. And listed on the slide are the type of questions that they asked in the survey.
Ja, det var på en måte da pasientene responderte på en del spørsmål. Det var noen utfordringer med det, men de punktene der som nedover på sliden var på en måte det pasientene svarte på.
So this just shows you that they had about 700 patients, even numbers amongst the diseases, and even split between early disease and late disease, and that many patients also had other conditions such as diabetes, for example.
Dette omhandler da 700 pasienter, og pasientene ble inndelt litt om det var tidlig I sykdomsforløpet og sent I sykdomsforløpet, og om det også var underliggende sykdommer som diabetes, lunge og så videre.
So the next few slides show the patients' grading of quality of life, whether they had to cancel planned activities and whether they called in sick. And they compared it to what was the prognostic risk for the patient and then how severe their symptoms were.
Denne slidesen viser da I forhold til pasienter som har måttet avlyse aktiviteter de har planlagt, og som har meldt seg syke, og så har de relatert det til da prognosen på den underliggende MPN altså.
So for myelofibrosis patients, for example, we can see that 80% of patients reported that symptoms impacted their quality of life, and that this correlated with prognostic risk, but there was a much better correlation with severity of symptoms for quality of life, cancelling of activities, and calling in sick for work.
Og spesielt da for 80% av pasientene med myelofibrose så viser på en måte den øverste delen der at de har da spesielt redusert livskvalitet og da høyere grad I forhold til å avlyse planlagt aktivitet og så videre.
A similar pattern also for patients with polycythemia vera, that we can say someone is high risk, but the impact on their quality of life, their ability to work, is more dominated by symptoms.
Og for polycythemia vera så innrapporterte flesteparten av pasientene også redusert livskvalitet. Og livskvalitetsscoren korrelerte bedre med symptomene, men ikke så godt med den prognostiske scoren til forskjell fra myelofibrose.
Interestingly, the same is also true for patients with ET.
Ja, og det samme fant man også for pasienter med essensiell trombocytose.
This is a very busy slide, so I pulled out some key messages for you. Around a fifth of patients with myelofibrosis and about 10% of patients with PV and ET said that there was a great deal of impact of their disease on daily activities, and that this had a great impact on their family and social life.
Om lag 21% av myelofibrosepasientene og 10% av polycythemia vera-pasientene innrapporterte om stor påvirkning på dagliglivets aktiviteter, og også 17% av myelofibrosepasientene og 11% av polycythemia vera-pasientene innrapporterte også som begrenset sosialt liv.
And some of this, I have to say, was a huge surprise for me. I didn't really have this feeling from my patients. And for example, there were some patients who had to cancel more than half of their planned activities and spend almost really a lot of time in bed.
Ja, hun syntes det var veldig overraskende å finne at nesten 50% av pasientene hennes måtte avlyse da planlagte aktiviteter og tilbrakte mye av tiden sengeliggende.
And this slide shows similar data for patients and their ability to work. Many patients reducing their work hours.
Denne slidesen viser da hvor mye man må begrense arbeidslivet som følge av sykdommen.
Or terminating their work, or stopping work, or taking an early retirement.
Så det går både på sykemeldinger og pensjonere seg på et tidligere tidspunkt enn man hadde planlagt.
I wonder if we have some similar information for patients in Norway. I think you're a very healthy population in general. So maybe we should challenge you to find this information out from your members. And of course, myelofibrosis in general was worse than the other diseases.
Og hun fant også at myelofibrose den sykdommen som gir aller størst symptombyrde.
And these are the conclusions from the first part of the American study. And some of these conclusions were very dramatic for me. I'd never thought about the impact of disease itself on a patient's working, for example. I understand coming to hospital is a nuisance, but I hadn't thought about the other findings, and the results should have a big impact on us thinking about how we plan support for patients and how we plan our treatments.
Ja, dette da konklusjonen på denne første studien, og hun finner resultatene veldig overraskende. Hun hadde ikke tenkt at mange pasienter har så redusert livskvalitet som følge av veldig høy byrde av symptomer.
There was a second study which was carried out in Canada, Australia, UK, Germany, Italy, not Norway. I wonder why not. And this was looking at some slightly different aspects, so I will share that data with you.
Så det da den neste studien som ble gjort, som var en multisenterstudie mellom blant annet USA, Australia og enkelte land i Europa. Men dessverre var ikke Norge med på denne.
Again, around 700 patients, good representation of our main family members in the MPN family.
Det var da 700 pasienter som ble inkludert i denne studien, og en veldig fin fordeling mellom de 3 ulike undergruppene.
More patients reported symptoms early at their diagnosis, but also another important point for me was that many of these patients were not aware of their medical prognostic score.
Noe av det som var overraskende ved de første resultatene var at mange pasienter ikke var klar over denne prognostiske skåringssystemet.
The symptoms were very similar to the symptoms I already showed you. Picking out, abdominal pain, sweating at night, and weakness for myelofibrosis, itching and concentration, particularly for PV.
Det var mange av de samme symptomene som innrapportert i den første studien. Som dominerende her var magesmerter, nattesvette, hudkløe og konsentrasjonsproblemer.
Finally, importantly, 90% of patients reported some symptom in the past year.
Og viktig å understreke, mer enn 90% av pasientene innrapporterte MPN-relaterte symptomer innenfor de siste 12 månedene.
The severity of symptoms, however, remained quite stable.
Alvorligheten av symptomene holdt seg stabil.
Interestingly, we also looked at severity of disease, symptoms and treatment. And we found some patients with a very high symptom burden and big impact on quality of life that were not receiving active treatment.
Noe av det som var overraskende på denne sliden som jeg forteller om, var at man fant at en god del av de pasientene som beskrev høyest andel av alvorlige symptomer, de fikk ingen aktiv behandling for sykdommen.
We asked in this survey, what is the symptom that you would most like to have resolved? And you'll see most patients referred to improvement in fatigue, blood clots, and then there were some other symptoms that we list on the bottom of the slide.
Pasientene ble spurt om hvilke symptom de aller helst ville bli kvitt, og det ble da innrapportert spesielt fatigue og tretthet, etterfulgt av bli kvitt blodpropper, så det var de 2 hovedinnrapporterte faktorene for hva pasientene ville bli kvitt.
We also asked, how do symptoms impact on quality of life? And we saw a very similar pattern to the American study, that around a quarter to a third of patients felt their symptoms really impacted very much on their quality of life. And there was some correlation with disease type.
Pasientene ble da spurt om hvor mye de var da enig i disse uttalelsene i forhold til lindring av symptomer, og de fleste partene, og spesielt myelofibrose, så det jo 36% som helt enige.
Great. Again, we asked about impact on work. And again, we saw similar findings, therefore validating the findings of our colleagues in America.
Og videre så var det jo da påvirkning i forhold til jobbsituasjonen. Også der finner man helt lignende resultater som det hun viste i den første studien.
So the conclusions really were quite similar to the American study, but we tried to make a very strong point that this previously unmeasured impact of these diseases on our patients needs to be part of our planning and needs to be part of the conversation with the health carers.
Som hun viser i konklusjonen her, så samsvarer disse resultatene veldig godt med den første amerikanske studien, og hun understreker at det er så ekstremt viktig å ha fokus på pasientenes symptomer.
So basically, we should be informing our future clinical practice and management from these studies, but also we should be designing our treatment strategies bearing this data in mind.
Og viktig poeng er også at når man planlegger behandling, så må man ha dette i bakhodet, så at det mye symptomer og redusert livskvalitet.
We have taken this a little bit further as a group of doctors, in particular myself, Ruben Messer, and some others, to measure again the impact of quality of life, but then to look at patients as they're starting a treatment. Is the treatment intervention improving this for patients or not? And maybe sometime in the future we can send you this data to share amongst your community.
Det som nå fokus på det videre arbeidet hennes å måle hva som skjer med livskvalitet og symptomer etter oppstart behandling.
In the landmark studies, we also found a gap between the goals of the patient and the goals of the physician. Maybe this is not a surprise to you.
Ja. Og det slik at i denne studien så fant man også at det var stor forskjell i hva doktoren forventet av behandling i forhold til hva pasienten forventet. Og det tenker hun kanskje ikke sånn veldig stor overraskelse.
This is a very complicated slide, but the point was, how is the interaction with your doctor or your physician, and how do they ask about your disease symptoms and quality of life? And the answer was a very mixed picture. Some interactions were very good, but some were less good.
Ja, dette som hun sier, en veldig busy slide, men hovedpoenget med den på en måte å finne ut av hvordan interaksjonen, samspillet, samarbeidet mellom doktoren og pasienten
Yeah. Maybe this is something that we need to have a conversation about how we make this better. Some patients didn't recognize in the studies that common symptoms, pruritus, might be related to their disease, showing a gap in patient education.
Ganske mange pasienter innrapporterte at ikke de visste at for eksempel hudkløe kunne være en del av et symptombilde ved polycythemia vera.
And when we asked, what is your main aim for treating a patient, to the physician and to the patient, some interesting stories emerged. For example, if you look at the colorful picture for ET patients, The patients with ET really, many of them wanted to focus on slowing or delaying progression of the condition, whereas for doctors this was really not a treatment goal, probably because we know that we're not sure that current treatments can do this.
Det som var veldig overraskende funn I denne studien var at pasientenes mål for behandling forskjellig fra doktorens mål for behandling. For eksempel når det gjelder ET, så ønsker mange av pasientene da at man på en måte forhindrer sykdomsprogresjon, mens dette var ikke et mål hos doktorene.
And notice that this difference is even more dramatic for patients with myelofibrosis, where almost half of the patients are focusing on delaying progression for treatment, but doctors this time really thinking about improving quality of life.
Man finner akkurat det samme ved mylofibrose, at veldig mange pasienter ønsker å forsinke stoppe sykdomsutviklingen, mens det kun en liten andel av doktorene som tenker på den måten.
So again, these findings are important and have influenced the conversations that I have in my team with my patients, and maybe they might influence the conversations you have with your teams or your doctors.
Dette veldig viktig, dette konklusjonen og veldig viktig funn, for det illustrerer jo at det et utrolig stort forbedringspotensial I forhold til hvordan doktorene kommuniserer med pasientene.
I think there's some water for you. Yeah, great, thank you. So in the last few minutes, maybe before we take a little break for maybe some questions, I wanted to talk to you about different models of care and how we provide care in our service in the UK, maybe before we have a discussion. Is that okay? And so I really like this slide because it makes people think not about a disease, but it makes them think about the person who is in front of them and how we make the care and how we design our care for the whole person. Of course, this is an aspiration, but I will usually show that when I'm teaching colleagues.
Hun synes denne figuren illustrerer veldig godt hva som hun synes veldig viktig, og det på en måte hvordan fokus skal være på den personen du har foran deg, altså pasienten, og ikke på symptombildet, og at man på en måte må individualisere og tilpasse til hver enkelt pasient. Hun bruker denne slidesen mye når hun underviser for kollegaer.
And some other things that are difficult. How to talk about this diagnosis. All in one go, over several meetings. Should we use the word cancer? Giving accurate information, and I'm so happy that your organization has information books that you provide to patients. And then thinking about the common questions that patients might ask. Why did I get this? Is it inherited? Can I have children? Can I travel? What things should I watch out for? So these are all things that we try to provide for our patients.
Det som hun trekker frem som viktig å fokusere på, det jo god pasientinformasjon og hvordan man tar i bruk ordet kreft når man snakker om dette, og hvor viktig det med både skriftlig og muntlig informasjon, og det at man kan svare og ha kunnskap om de mest stilte spørsmålene som diett i forhold til om dette kan være arvelig, graviditet, reise og hvilke symptomer man skal være obs på.
So some things that we try to put around this picture, we need to think about medical knowledge. We need to provide input about inheritability. We need to do education of the patient and their family doctor. We need to have a wider team that includes psychology, that might include a cardiologist, and will provide more support to the patient and their family.
Det viktig å på en måte ha pasienten i fokus, og det å trekke inn flere instanser rundt pasienten, det med å utdanne pasienten i sykdommen med god informasjon, og kanskje også ha andre spesialiteter rundt, som kardiolog og sykepleierspesialist og så videre, altså et team rundt pasientene.
So, a few information about the service and the design of healthcare in the UK.
Hun skal si litt om hvordan opplegg de har på sitt sykehus og i England.
The most important two people in my team are shown in this picture.
De to aller viktigste personene i hennes team viser hun på dette bildet.
Notice they are not doctors.
Og de ikke doktorer.
They are highly experienced nurses with whom I've worked for over 10 years.
De da spesialsykepleiere med lang erfaring innenfor dette, og hun har jobbet med de i over 10 år.
This is some information about the concept of what's called a key worker, an individual person that every patient has the contact details for. Usually it is a nurse. And this is a quote from the documentation around that role. Constant attention by a good nurse may be just as important as a major operation from a surgeon.
Og det hun understreker altså det hun kaller for key working, altså at det en slags nøkkelperson med høy kompetanse innenfor sykdommen. Det kan være som da hun illustrerer ved altså at en god sykepleier like viktig som en kirurg altså.
Now this is quite a unique role to the UK, I think. So this person is a constant point of contact for every patient through their disease pathway. Our patients can email this person, they can phone them up. They are there for most of the difficult consultations, and they provide some of the monitoring of patient care.
En slik høyspesialisert sykepleier vil kunne være tilgjengelig hele forløpet og være en kontaktperson som kjenner hver enkelt pasient veldig, veldig godt, og som gjør at man har et sted man kan henvende seg til, stille spørsmål og så videre, og bidrar betydelig til at bedre et forløp for pasientene.
For example, we also have other teams. We have a teenager and young adult service. There's a picture of them here at the front of St. Thomas's Hospital. They provide support for young patients. This is something I want to do in the next few years, set up something special for young people with MPN.
Det bildet hun viser her et eget team som de har for å støtte yngre pasienter med MPN, og det noe hun ønsker å ha fokus på de neste årene, og ha laget et enda bedre team rundt de unge pasientene.
Here's an example of the support given to a young boy who came to our service. He was studying in Scotland. He felt very tired. A diagnosis of ET was made. His mother, I understand this, I'm an anxious mother myself, made a referral to our service.
Ja, dette var da en 19 år gammel gutt som fra Skottland, som da hadde symptomer som fatigue og veldig høye plater, og fikk diagnosen essensiell trombocytose med den kallretikulin positive mutasjonen, hvor moren ikke var helt enig i den diagnosen, så derfor så kom han til deres senter, og da ble diagnosen endret til primær myelofibrose.
So the change in diagnosis was a big shock for him. So we had to put a lot of support around him. He's been attending the service with the team, but we also put other support. He contacts the team using WhatsApp. He sees a psychologist, and we put in a lot of extra support for him.
Det at han fikk endret diagnose til myelofibrose var et stort sjokk for han, slik at det var et stort behov for nettverk rundt han. Og da hadde man blant annet mulighet til å kontakte dette teamet hun viste på forrige bilde gjennom WhatsApp, og det var også psykologer og muligheten til å sende mail til klinikken da.
We also have a service which was set up to try to help with fatigue. We don't have very good treatments or managements for fatigue, and maybe this is something we can discuss in a few minutes. So we have a service with a physiotherapist and an occupational therapist. Do you have those in Norway?
Occupational therapist.
So they advise about exercise, activity, diet, and they've been really helpful for managing our patients with fatigue. But they recognize that MPN fatigue is very different from cancer fatigue.
De har også et eget team på sitt sykehus som har spesielt fokus på fatigue, deriblant bestående av fysioterapeuter. Men dette teamet synes at den fatiguen man får av MPN på en måte noe vanskeligere å behandle enn da fatigue etter andre krefttyper.
And of course we have the patient advocacy like your group. This is really important to support patients. We set this up a little while ago, but it's growing and learning from partner organizations.
Og I tillegg så har de støttegrupper, sånn som I Norge med Blodkreftforeningen, som viktig.